I'm Zvonimir Krajcer. I'm an interventional cardiologist at Texas Heart Institute in Houston, Texas. The topic of this presentation is complication post-EVAR. A clinical presentation pertinent to this particular case is here. 61-year-old male was sent via air ambulance to our institution with complaints of severe back and abdominal pain. His past medical history was pertinent for hypertension, hyperlipidemia, coronary disease, status post previous coronary bypass surgery, congestive heart failure, cardiomyopathy, and he was status post heart transplant 5 years prior. 3 years prior, he had a successful EVAR at our institution. Despite several attempts to contact the patient to return for a follow-up, he did not return for a follow-up. On admission, the patient's vital signs revealed blood pressure to be 98/60, and his heart rate was 110 beats per minute. His abdomen on examination was tender and distended with normal bowel sounds and very pulsatile and tender aorta. His lab revealed hemoglobin was down to 8.2, and white count was slightly elevated, 11,000, and creatinine was 1.5. He had a CT done elsewhere prior to this transfer of the abdomen and pelvis, and the CT revealed evidence of contained rupture of the abdominal aortic aneurysm with large peritoneal hematoma, as seen in the images here. On the left-hand side, we could see that the aortic diameter at the right renal artery was 24 millimeters. And on the right-hand side, with the red arrow, we can see ruptured aneurysm and also migrated stent graft with a pretty large endoleak. So 3 years prior to this, he was referred to our institution for elective EVAR, and at that time, neck diameter was 23 millimeters. Neck length was varied between 23 to 40 millimeters, depending whether you include the accessory left renal or not. And the maximum diameter of the aneurysm was 60 by 58, as shown here. His abdominal angiogram 3 years prior, at the time of his EVAR, we can see here on the right-hand side, as far as measurements are concerned, the distance from the right renal to the origin of the aneurysm was 46 millimeters, and from the accessory left renal to the aneurysm, it was slightly over 23 millimeters, which we thought was successful to have a good seal if we intend to preserve the patency of the left accessory renal artery. The procedure was done under local anesthesia and percutaneous approach with Gore excluder stent graft. We pre-closed the access site with 10 French ProStar for left and right access sites with 12 and 18 French sheets. And we used a 28.5 by 14.5 excluder that was 160 millimeters in length on the ipsy side. And then we used a 20 by 115 millimeter right iliac limb. We can see the completion angiogram on the left-hand side, where the red arrow shows a preserved accessory left renal that supplied about close to 50% of the renal parenchyma, and the stent graft was well positioned, and there was no evidence of endoleak. He had, at that time, uneventful recovery, and he was discharged from the hospital the following day. Now, on this occasion, he was admitted with ruptured abdominal aortic aneurysm, and you can see on the left-hand side in a still image, and on the right-hand side a dynamic image, and evidence of migration of the stent graft down to the aneurysmal sac, and that was a excluder stent graft. So we brought him to the endovascular suite, and we performed angiograms percutaneously of his right and left renal arteries, that's shown on the left-hand side. And then we proceeded with coil embolization of the left accessory renal that was now at the site of the ruptured aneurysm. So this artery had to be excluded to achieve adequate seal. And then we performed EVAR, as you can see on the completion angiogram, showing the position of the stent graft just below the origin of the left and right renal arteries, again with a 28 millimeter excluder stent graft that's 14.5 millimeters in diameter distally and 14 centimeter in length. So this excluder was placed within the existing excluder that we can see lower down right here. So this is the completion angiogram, showed successful results with excluded ruptured aneurysm and no evidence of endoleak. So what are the learning points in this case? Surveillance post-EVAR is extremely important to avoid complications, particularly for patients with complex anatomy and comorbid conditions like in this particular patient. Endograft migration and type 1A endoleak usually leads to serious complications. Ruptured abdominal aortic aneurysm can be successfully treated with percutaneous approach, as shown in our case, and local anesthesia, even with the ruptured aneurysms. The question is, what caused the endograft migration in our patient? Whether it was loss of structural integrity, such as breakage of the anchors or endo anchors that secured the graft in the infrarenal position, or it was due to diseased aortic wall that continued to dilate and deteriorate over a period of time, is not perfectly clear. And obviously, this is open to discussion. So what is very important also is to obtain as much seal as possible whenever performing EVAR. So should a different endograft that has a separation of the fixation from the seal zone offer better result? In this case, it's not clearly known. And again, it's open for discussion. Thank you very much for your attention.